and welcome to VIVA in Las Vegas. My name's Nick West. I'm the Chief Medical Officer at Shockwave Medical. I'm delighted to be joined today by the two co-principal investigators from the recent DISRUPT PAD BTK II study, presented as a late-breaking clinical trial here alongside our forward PAD data. With me today, Dr. Ehrin Armstrong, who is the Director of Clinical Research at the Advanced Heart and Vein Center in Denver, Colorado, and Professor Venita Chandra, who's the Director of the Limb Salvage Program at Stanford University. Welcome, both of you. So maybe let's just start and talk a bit about the study. Ehrin, what was interesting to you about this study and why do you think it's important?
Yeah, well, I think that when we look at the DISRUPT PAD BTK II study, the reality is that when we look at different vessel beds of patients with severe calcification, the below knee segment just overall fundamentally remains understudied. I think Shockwave has done a great job of developing data in the BTK space, but to have a trial that's specifically focused on the treatment of tibial disease, I think really helps us understand both the acute results of these patients, which was presented here now at VIVA, but importantly, we'll also have long-term data coming out over the next 1 to 2 years.
Yeah. So Venita, you presented the late-breaking data. So the patient population is kind of unique in this space. And so tell us a bit more about the features of this population that make it more like a real-world study than some other studies in this space.
Yeah, it's so refreshing to have a below-the-knee study with true CLTI patients. These are patients with all of the comorbidities, long lesions, heavily calcified. We included dialysis patients. I mean, all of those things I just said are essentially excluded from every other below-the-knee trial. So it was just very refreshing. And I think the power or the beauty of it is that those are the patients that actually serve to benefit the most from this technology. So it's exciting to have them be able to be enrolled and see what the outcomes show.
Yeah, and I think those are some of the things you've hit on there are some of the very important points about as you say, the high prevalence of calcification, obviously, for an IVL study is important, but it reflects what you see out in the real world, doesn't it? And as you say, Ehrin, this is an unmet need.
Very well put. It's true. I think this was more so than any other, even below the knee study that I've seen before, a real world study. You know, the fact that patients on dialysis were included is somewhat unprecedented. And the fact that this was a core lab adjudicated study, you know, we have a lot of data in the below knee space, but so much of it is single center or non-core lab adjudicated. So it's very difficult to tell what's really happening at the lesion level. So I think with this data, we're going to really be able to parse out the optimal way of treating patients with advanced critical limb ischemia.
Yeah. I'm hoping that most of our viewers or listeners are familiar with the outcomes of the study. But Venita, maybe you just want to hit on the high points of what did the study show in terms of safety and efficacy?
Sure. Well, obviously, we just presented 30-day outcomes, which are really quite acute. But what we found was excellent safety profile. We had just 3 adverse events, really, and 2 of them were because of mild perforations caught on core lab adjudication, not caught by the physicians, and no clinical significance. No mortality, which, you know, yes, it was only 30 days, but again, we have those really, comorbid patients in this population. In terms of efficacy, again, at 30 days, what we found was really the acute benefit in terms of decrease in residual stenosis or increase in MLD. So it was very promising. I kind of made the comment at the late-breaking event that if you look at the charts of decrease in stenosis with IBL, like across every bed, they all look exactly the same. Yeah. Majority goes below 30% after IBL, and that's exactly what we saw so far on this cohort as well.
Yeah, and the primary endpoint, as you'll know, was diameter stenosis less than 50, which was achieved in more than 90% of patients.
Yes, 97, only 96%.
But 3/4 of the patients achieved a residual stenosis of less than or equal to 30%, which is pretty good.
Right.
Because the use of adjunctive devices was low, wasn't it?
Very low. There was a less than 5% stent rate, and that's about it. I mean, that's half of what was seen in the below the knee cohort of the observational study.
Yeah. And half of those actually were by choice rather than clinically mandated per protocol, weren't they?
Exactly.
So that's fascinating. So what do you think, for people who haven't looked into the trial, we talked a bit about the patient demographic, we've talked a bit about the safety and efficacy data, which, as you said, Venita, it mirrors almost everything we've seen with the Shockwave trials. Is there anything you think people are going to find particularly exciting or difficult to explain?
I mean, I think, as we were just mentioning before, the fact that the majority of these patients achieved a residual stenosis less than 30%, to me speaks to the efficacy of IVL in the tibial segment and the consistency of the data. Having presented, the observational study multiple times and the randomized data, it looks the same in every single vessel bed. And having that improved luminal gain and minimal residual stenosis, I mean, the flow matters. And I think that the fact that you can get to that minimal residual stenosis with essentially no use of other adjunctive therapies, speaks to the ability of the Shockwave and IVL to be essentially a standalone therapy in many cases for these tibial vessels.
Venita, when you presented, you talked a bit about the wounds. So clearly 30 days is quite early to see wounds healing. But given the fact that half the patients had a wound at presentation, early to say, are you encouraged by the signal that was seen?
Oh my goodness. I would say I was quite surprised by seeing a signal already. I mean, I run our wound care center. No matter how good your revascularization is, it does take some time. And to already see a benefit, I mean, you could already see a significant improvement in Rutherford classification. And, more than 50%, I think it was 60 some percentage of patients had either healed or healing weight.
And I think, we have to take it slightly with a pinch of salt. We weren't that rigorous in this study at capturing wound data. There wasn't core lab adjudicated. It was, but nevertheless, it is a signal. And I think it's very, very encouraging because after all, for the majority of these patients with CLTI, the end goal is wound healing. It's really nothing more than that. Reduction of pain, wound healing. And one thing I think that you mentioned about Rutherford class improvement, one thing I think we haven't hit on in our discussion so far is that this trial is unique not only for the demographics in terms of the calcification, but in fact, we had quite a small amount of Rutherford 3. It was mostly 4 and 5 in the study, wasn't it?
Right. I mean, you can somewhat argue that a Rutherford 3 is a different beast, right?
For sure.
Certainly talking about a different cohort. And I think what we did that was really thoughtful in the study was limit the number of Rutherford 3. And there was under 20% were Rutherford 3. So we're really, like I said, once again, talking about the most difficult patients, the Rutherford 4 and 5. Allowing lesions up to 200 in length is unheard of, I think, in a below-the-knee study. So again, just real world and challenging patients.
And I guess a bit surprising that the average length of the lesions was about 80 millimeters in the study, just under 80, when you could have had up to 200. But nevertheless, many of the BTK studies have much shorter lesions. Some of the DCB studies, the scaffold studies, have much shorter lesions, which don't really represent real world. Going back to the outcome data, you spoke about wounds. I think, Ehrin, you'll have seen the quality of life improvements. And again, much like wound healing improved at 30 days, maybe too good to be true. Again, quality of life was different at 30 days as well.
Yeah, it's pretty impressive. But even, at the 30-day endpoint, there was already statistically significant improvement in quality of life in these patients. And some of that may be related to the wound healing, honestly, because the presence of an active wound, dramatically affects somebody's quality of life. These are patients who may have to go to the wound care center twice a week. It interrupts all of their daily activities. So I'd be interested as we continue to analyze the data to see if the relationship between that early wound healing is a major driver of quality of life improvement. But I think it speaks to the fact that, these other people, even those who didn't have a wound, appeared to have significant improvement, probably in their rest pain or claudication symptoms as well.
And much more to come from that. As you say, we're going to be following these patients out to 2 years. So of all the things we've spoken about in terms of the safety signal, the efficacy signal, the wound healing and the quality of life, what are you most looking forward to seeing as the trial progresses in terms of a meaningful improvement from a clinician and patient point of view?
Yeah, well, the wound healing data I think is very fascinating, and I'll be very curious to see the 6-month data with regards to the percentage of wounds that have healed by that time. We're also going to have long-term patency data as well, and so I think that's pretty unique for a below the knee study to have core lab adjudicated patency data, especially these heavily calcified lesions. So I think the 6-month and 1-year data are going to be really informative in that regard.
Okay. And Venita, any predictions then? What are we going to see as the trial progresses?
Well, what I always say, and perhaps I shouldn't say this after we talked about a study where we're looking at patency out to 2 years. I don't really care about patency, right? I want to ease their suffering of my patients and heal their wounds. And I think one of the ability to really get adequate true luminal gain with this technology that we are seeing in the acute studies is going to really manifest like continued benefit in that way. So we'll see.
Well, thank you both very much indeed for joining me today to discuss the trial, the utilization of IVL in the BTK space. I hope that everyone's enjoyed our conversation. So thank you very much, and cheerio from Las Vegas.